Top Med Talk.
Day 2 of EBPOM Chicago, lunchtime sponsored session, graciously sponsored by Edwards Life Sciences. I'm Desiree Chappell. I'm a CRNA from Louisville, Kentucky, and Vice President of Clinical Quality for North Star Anesthesia. And I'm joined today by Professor Monty Mythen, Professor of Critical Care and Anesthesia from the University College London. Hello, Monty.
Hey, Desiree. This is a new experience. I mean, not only that we've been emphasising the fact that we're actually physically here in the same place after a long time, but we're having a lunchtime session as the sun sets over the west coast of Ireland. So it's our interdigitated meeting, because we're looking out the window here and the sun is going down, but it's a lunchtime session. We're all over it. We're good.
This session is about intraoperative hypotension.
Yeah.
And we've talked a lot about that at our EBPOM meetings and on Top Med Talk, but we're digging in a little bit deeper, aren't we?
There are more papers coming out the whole time, and there are new challenges, and we're going to go into some detail in one paper that's been out for a little bit. We've covered it a couple of times on Top Med Talk, but it's a very big observational study that I think we should reflect on. And then we're going to go to two other studies that might confuse people a little bit about whether intraoperative hypotension is or isn't important in certain circumstances. The other two things that are coming out in various discussions and editorials is surely it matters how you become hypotensive, and that might be picked up in these observations. You know, if you're bleeding, hypovolemic, low flow shock, surely that's different to vasodilated, anesthesia-induced low blood pressure. Is it or isn't it? And the final thing is, if you decide in the interim you're going to keep the blood pressure up, surely it's not just as simple as starting a vasopressor infusion. So we'll try and get through all of that.
Let's go ahead and bring our guests in. Friend of the family, friend of Top Med Talk. We've heard him here today at the earlier lunchtime session, Thomas Scheeran. He's professor of anesthesiology at the Department of Anesthesiology, University Medical Center, Groningen in the Netherlands. Thomas, how are you?
Fine, thank you, Desiree. Professor of anesthesia in Groningen in the Netherlands, that has been said before. And I'm originally from Germany, where I was educated and worked for 30 years. And the last 10 years I worked in the Netherlands. I'm a researcher, a clinical researcher, and I'm very much interested in hemodynamic monitoring and hypotension and blood flow going also to the organs and to the tissues, so even to the microcirculation. So these are my topics of interest. And I mostly work clinically as a cardiac anesthetist in the OR.
Well, I can't wait to get into more conversation here in just a minute, but I'd like to bring in our next guest, Ashish Khanna, who's an associate professor and vice chair for research, the Department of Anesthesiology in Section on Critical Care Medicine at Wake Forest School of Medicine. Ashish, thank you so much for taking time to join us.
Thank you, guys. It's a pleasure as always. But yeah, so in maybe about 5 years of working around perioperative outcomes, my work essentially focuses on why patients deteriorate both within and outside the ICU. So clinically, I practice most of my time in post-surgical ICUs. You know, I have focused my interest on hypotension within and outside the ICU, and also because no hypotension in the ICU can be separated from hypotension in the operating room. So it goes without saying that hypotension is a continuum, and I have focused on that continuum of care. I do believe that we need to step up the level of monitoring and the types of monitoring we have on our patients. I also do believe in the value of trying to understand what patients will do well and what patients will not, and trying to proactively intervene. I think we've spent a lot of time talking about the fact that hypotension is bad. I really do feel that we need to move on to the next step and intervene and talk about how to prevent hypotension. So that's, what I've done and what I'm interested in. I'm going to add that I'm excited to see my dear friend Thomas Scheeran today, who I had the honor of meeting over breakfast just a few weeks ago in Brussels. So, we've actually met each other.
Oh, good for you in this virtual world. It has been difficult. But thank you so much, Ashish. Monty.
Gentlemen, you've both been really prolific in publishing in this space, and I've chosen 3 papers for us to concentrate on to discuss. I think they're certainly very, very familiar to Ashish because he's an author on all 3 of them. I'm not trying to undermine your brilliant work there, Thomas, but I've chosen them to highlight where we stand with the observations of hypotension and their relationship to outcome, because there's potentially a few little confusing messages in here. So if I could get my laptop up there for a second to share. The first one I've chosen, which we've had the privilege to cover a number of times on Top Med Talk. Anne Gregory, who's the first author, won our poster prize the last time we were allowed to have a physical World Congress in London at the British Museum. I'll go over the detail of it in a second. And then the last time we were physically at the ASA, we interviewed Andy Shaw about the detail of this. And you'll see in the authors there that Ashish, our guest, is one of the co-authors. So the paper will be very familiar to him. And to remind people about this study, it's a large observational study that I think was prompted by the fact that up to this point, we'd been taking a lot of our information from, in recent years, from a single centre. Fantastic work done by the Cleveland Clinic. But there was always the possibility that the Cleveland Clinic data in isolation would not be replicated when you looked as many places as you could manage to look. And this is a study of very many centres in the USA, looking at, as far as I can see, over 360,000 surgical procedures. And the conclusion seems to be that whether the threshold for a mean arterial pressure is 75, 65, or 55, that it's associated with postoperative harm. And in this particular thing, we'll ask Ashish to explain it in a second, it concentrates on MACE, M-A-C-C-E. So Ashish, am I getting that right from the big picture perspective?
Yes, coming into the study, one of the big issues was that, number one, yes, hypotension data was mostly single center, and I have been part of that group at Cleveland Clinic, and Dan Sessler and colleagues have truly established the empirical definition of hypotension with all the work that they've done. But yes, we wanted to see whether that would be replicated across many centers in the US. We also wanted to see whether how we measure and define hypotension makes a difference in outcomes. So in this paper, you'll see that we looked at different ways of measuring hypotension. So whether it was absolute cumulative time or standard average or an absolute maximal decrease or an area under the curve, we wanted to show and prove that each of these methods, was there a particular method that would have a more significant association with perioperative harm. That was another reason why we wanted to do this investigation. Furthermore, we wanted to look at possibly what is now the largest published data set of intraoperative hypotension. And then we also wanted to extend it out forward into the postoperative period. And you're going to, that's a different paper. But when we started, we wanted to say, let's take a patient who starts hypotensive in the operating room, and let's keep going with that patient out into the postoperative period, both on the general care floor and into the postoperative ICU.
Thomas, any additional reflections to add on this paper? I know you've contributed a lot to this area as well. Do you think we can stop measuring this one now? We kind of we've done collectively done a fantastic job in observing. Is there anywhere else we need to observe?
I want to like to say that this is very important work, because now we know with big numbers, so big cohorts, that hypotension matters, that hypotension is a dangerous thing, that hypotension harms the patient, and that the harms are myocardial injury, but also kidney injury, and maybe also cerebral injury. So this is great work, and I'm very thankful for both the Cleveland Clinic group and all the others that have done this work, which is a foundation of our research. The only thing that I would like to remind us is that this are population-based thresholds, so they are valid for big numbers of patients. But for the individual patient that is just lying in front of you, these values might not apply. So we have to be a little bit careful by applying these general thresholds derived from big populations to the individual level. So I think we still need to individualize those levels in our patient in front of us.
On that point, and it's a very potentially complicated graph I'm showing here directly from the paper. On the left-hand side, marked A as you look at it, is what Ashish was referring to with regards to different ways of analysing hypotension. On the right are the secondary outcomes. So at the top, it goes 30-day mortality, and then acute myocardial infarction, acute ischemic stroke, acute kidney injury, the requirement for dialysis, delirium, 30-day mortality, and SIRS sepsis. And for all of those secondary outcomes, as the level of blood pressure drops, it looks as though the signal gets stronger, sometimes not that much stronger. So it looks as though harm starts at 75. Ashish, any theories on why there was no signal from stroke? Because you'd think that would be potentially one of, and this may have been touched on by in some of Thomas's comments.
Yes, when we look at large data sets like this, we have to understand that data is whatever you and I feed into our EMRs. So these large data sets essentially rely on clinicians to document everything precisely, because when you do an extraction from these large data sets, for example, for something like an acute ischemic stroke, you're not going to go in and look at the symptoms of a patient that would be suggestive of a stroke. You're probably looking at ICD diagnostic codes or some such measure to pull out something that says acute ischemic stroke. And that's where sometimes these large data sets can get slightly messy. Specifically, we're trying to look at a more precise diagnosis like acute ischemic stroke, or even for that matter, acute myocardial infarction, which we all know, we, for example, could not get to myocardial injury, which I would have preferred to in something like this. It's probably way more sensitive than acute myocardial infarction. Similarly, with acute ischemic stroke, I'm not sure that the data set really did justice to defining and allowing us to extract all patients with acute ischemic stroke. So that, for me, in fact, if you look at all the secondary outcomes, that's why you do see a clear signal, but you also at times don't see a very stepwise progression of harm as blood pressure drops lower, because there is an element of noisiness to large data like this that, comes from our system in the US, because again, that's what you sacrifice when you go to many hundreds and thousands of patients versus a single center and 30,000 patients, where you know the quality of the data and you know the cleanliness of the data, for lack of better word. So that's how I would best justify that acute ischemic stroke being sort of non-specific as far as its association with hypotension. Although there's been others who have obviously justified that in publications as well, that acute ischemic stroke and association with perioperative hypotension is not as strong as some of the other organ system injury that we know of.
Thomas, any extra comments on that before I move on to the next bit?
Yeah, I would just like to mention that the cerebrum has an autoregulation of its blood flow, which is mainly keeping blood flow constant within certain ranges. So unless you have very low blood pressures, maybe the brain is able to keep its blood flow constant despite the mild hypotension we are now talking about.
Thank you. I'm now going to take us into the area where some people might start to get a little bit confused. So the first one, I think, is probably pretty straightforward, if I'm reading it right. Ashish, you're the senior author on this paper, published in Critical Care in 2020. Postoperative hypotension in patients discharged to the ICU after non-cardiac surgery is associated with adverse clinical outcomes. Now, we could turn around and say, well, yeah, you've just told us that, haven't you? What's the difference in this paper, Ashish? And just before you give the game away, I'm going to show the other paper in a moment, which is the one that potentially introduces some confusion. So could you just expand on this, Ashish?
So like I said, when we initially started this work, our idea was to take a patient through the entire perioperative journey from the operating room to either the ICU or the general care floor or both. Previous work that myself and others have done specific to the postoperative ICU has shown that hypotension-associated harm in the postoperative ICU is dependent on intraoperative hypotension. So we could not separate intraoperative hypotension from hypotension in a postoperative ICU. I published that work in Critical Care Medicine 2019, and I right over there because, that work that I published basically showed that if you're hypotensive in the operating room and you're also hypotensive in the ICU, then you have organ system injury. But the risk of organ system injury is dependent on intraoperative hypotension. Well, we all know that, our patients don't do well in the operating room. They come to the ICU, they continue to do badly, and they're going to have organ system injury. So this time we wanted to look at the patient who did not have any intraoperative hypotension. Rock solid patient intraoperatively comes to your ICU and now has new hypotension. Does that patient have a similar sort of risk associated with hypotension compared to the usual patient that, bleeds a liter or so in the operating room, then comes to you in the ICU, right? So that's sort of was for this work. And just to clarify the confusion point, the other paper does not take patients to the ICU. It takes patients to the general care floor. So that's how these papers are divergent. The other patient is a patient on the general care floor for postoperative hypotension. This is a patient in the ICU that did not have any intraoperative hypotension.
Okay, I'm just going to repackage that to make sure I got it straight. A subset of patients with no intraoperative hypotension go to the intensive care unit and get hypotension, and that hypotension is still associated with harm. Correct, Ashish?
Yes. Yes, okay. That's correct.
So we're just going to flash up the other paper, because when you read them side by side, you think, man, I'm losing the plot here now. Because this is this is just under 70,000 patients undergoing non-cardiac surgery, postoperative hypotension and adverse clinical outcomes in patients without intraoperative hypotension after non-cardiac surgery. Sounds the same superficially. Conclusion: the postoperative hypotension, if it wasn't there intraoperatively, was not associated with harm. Okay, but the difference I think you're telling me is these are patients who didn't go to ICU.
Absolutely. This is your patient on the general hospital ward. And I'd love to make an extra comment at this point about, why I feel that we didn't get that harm signal here. Although personally, I feel that all of the hypotension on the floor is the real hypotension that matters, but we did not see it here. Can I make that point?
You can, and I think what we're saying is that intraoperative hypotension followed by on-the-floor hypotension is bad, but it's possible that on-the-floor hypotension without intraoperative hypotension may not be bad. Is that possible, Ashish?
Simplistically speaking, I will say that... Now we're trying to get really complicated. Hypotension in the operating room is bad. A patient who is hypotensive in the operating room and is also hypotensive on the floor, I believe that is bad. Our work did not conclusively show that it is bad. And I think the reason there is that we don't measure hypotension enough on the floor. So again, this work comes from a large data set where, folks have blood pressure checked every 4 to 6 hours on the floor. As we all know, the blood pressure checking on the floor misses large periods of time where folks are hypotensive. So clearly that's the lack of adequate measurements on the floor sort of makes our conclusions look fairly insignificant. But take the same patient to the ICU. Patient does not have hypotension in the operating room, has hypotension in the ICU. Things are pretty bad. So I know it gets, it's almost like we're trying to skin a cat from various different angles, but I think we're trying to make the point that hypotension is bad and that there are certain times where we don't measure blood pressure as much as we should. And if we could, then things would be very different.
Okay, Thomas, how did you interpret these papers?
I just want to stress what Ashish just said. We don't know anything about the ward. So it's a black hole in terms of hemodynamic monitoring, at least in our hospital. On the general ward, we have 36 to 40 patients with maybe 5 nurses on daytime and 2 at night. So they come, measure your blood pressure maybe once in a shift. So this is 3 times a day. So this is a very intermittent measurement. So we miss a lot of these hypotensions. And we also do not measure regularly in all the patients the markers that would point us to some organ injuries like acute kidney injury or myocardial injury after non-cardiac surgery. We need to measure troponins for that, for the latter, for example. We don't do that if it's not a cardiac patient. So we miss a lot of these complications. And this is something that we have to work on and to make the patient safe after surgery, because at the end of the operation, our surgeon calls the patient and says, oh, the operation is gone, the patient is fine. But this is maybe not true, because then the trouble starts in terms of hemodynamic management.
There's been some editorials coming out now and some discussions about the fact that there's alternative views on the hypotension story. And surely how you become hypotensive is an important variable that we don't have enough information on yet. Where do you stand on that?
Yeah, as you just said, we could, of course, theoretically at least, avoid all hypotension by just starting a drip of vasopressor from the beginning of the case, high dose. This way we could avoid any hypotension, I'm quite sure. Not thinking about the side effects of such a treatment. But this is not the causative treatment in all your patients. There are three main reasons for having hypotension. You could be hypovolemic due to blood loss or whatever. So a preload problem. It could be an afterload problem, so vasodilation as induced by many of our anesthetics. Or third thing, it could be a myocardial contractility problem, also caused by some of our anesthetics. And depending on that mechanism, the management of the treatment of that hypotensive event would be very different. It would be volume in case of the preload problem. It would be an inotrope in the case of the myocardial contractility issue, or it would be a vasopressor, but only in those cases where the afterload is low. So very, very different treatments according to the cause of hypotension. So the result being hypotension does not tell us automatically what the reason is, and we need information about the reason so that we can treat it accordingly.
Because Thomas, I think a discussion that we're going to continue to have is if you maintain volume, so you're slightly hypervolemic, for example, and you maintain flow, so you're slightly hyperdynamic, do the organs actually require a head of pressure than is anything other than very, very low? In other words, the capillary closing pressure. You know, when we used to do cardiopulmonary bypass back in the day and allowed the pressures to be 25 to 35 millimeters of mercury, the vast majority of people are still waking up alive with their organs intact. Does any organ require a head of pressure that we're discussing in the sort of 55, 65, 75?
Well, an organ, of course, does need a perfusion pressure, which is the difference between the inflow pressure, so being mean arterial pressure, and the outflow pressure, which is usually central venous pressure, or for the brain, it might be intracranial pressure if it's higher than central venous pressure, or for the kidneys, it might be intra-abdominal pressure if that is higher than central venous pressure. So the difference between the inflow and the outflow pressure determines the organ perfusion. To answer the first part of the question, we can say that even if we keep the flow optimized, for example, by doing goal-directed therapy, and we did that in a study together with Simon Davis from York. We applied very rigidly goal-directed therapy to all the patients. So we optimized them in terms of flow and volume. And still, 87% of those patients got hypotensive. So keeping the flow optimal does not prevent hypotension. So again, showing that even if the preload is okay, there are other reasons for getting hypotensive.
Ashish, thoughts on how the patient becomes hypotensive, and if you have more information on that, or if we can get more information on that?
You know, when we look at all of this work retrospectively, then obviously we introduce an element of confounding that is difficult to control for. If a patient has a myocardial event during surgery and gets hypotensive because of that, and then dies 3 days later, Now, you could always argue that the hypotension did not cause the myocardial event, but the myocardial event caused more hypotension. I can make similar arguments for, sicker patients being more hypotensive, and then, the degree of sickness driving the hypotension and leading to worse outcomes. And I guess that's where we struggle a little with, large retrospective data sets, because it's very difficult to tease out, what came first, the hypotension or the organ system injury, or both occurred together. But we do try our best, but we sometimes struggle. I think the best answer is to actually do an actual prospective trial where you could separate patients or stratify them into the types of hypotension, and then to follow them out and look at the extent of harm, which hasn't been done so far to my best knowledge. I know we sort of struggle with truly prospective randomized trials when it comes to hypotension because of various reasons. You cannot really make folks hypotensive. It's sort of ethically questionable. But then I still believe you can look at different blood pressure targets within certain degrees of comfort, and then follow those patients out and then sub-stratify them into the reason for hypotension and see if the type of harm is different.
The other thing that I want to add is, if you look at retrospective data, you don't take into consideration the treatment that is taken by the anesthesiologist, because in most of these patients, there is an anesthesiologist or an anesthesia care provider next to it, and he will tolerate the hypotension very much, I suppose. So he will do anything about it, but we don't know if that was the right treatment based on the reason behind the hypertension. So this is the problem looking at retrospective data.
So Desiree, if I may, you're Vice President of Quality for a large North American healthcare system, and I believe you're one of the systems that's engaged in the quality initiative that sort of says that you should look more closely and try and avoid periods of hypotension. Can you touch on that for us, please?
Yeah, so you may not know this if you are not in the U.S., but we have a merit-based incentive program that is directed by the Centers for Medicare and Medicaid. And it's a reporting program where we look at quality measures. And many of the quality measures that we've been reporting on are usually subjective. So did you give post-op nausea and prophylaxis? Did you give your antibiotic? Things like that. One of the things that the measures, as they go forward, and we get new ones every year, they're trying to focus in on more objective measures that we can look at. And so through the AQI, the American Society for Anesthesiologists Anesthesia Quality Institute, the IOH measure, the intraop hypotension measure, looks at providers maintaining an intraoperative mean arterial pressure above that 65. So they've designated it as 65 in order to reduce the risk of adverse outcomes. And they are looking at that objectively through reporting through electronic health records and using particular systems. And in this case, it's called Provation. And they are doing data pulls for us and then reporting those.
And this is going to be a many-year journey typically to make quality improvement. Do you have any sense of where you are and how that journey's going, and any discussions about how do you keep the pressure up? Because if you incentivize somebody to keep the pressure up, we've been discussing the complexities of you can do that the right way and the wrong way.
Yeah. It's really important for us as North Star Anesthesia to focus in and look at this particular question. I mean, we have over 180 facilities, so we have, not all of them are obviously on electronic medical records, but we have a birth of information that we can look at. And so we're really trying to dig in and see, if there is a signal of harm if we are experiencing intraoperative hypotension. So we're just digging into the data, working with some different organizations and groups to help us kind of dig down into that, to look across our footprint.
And do you think you'll be able to pick that apart a little bit and be able to say, well, they look as though they might have not had enough volume and they look as though they might have had a bit too much vasopressor? Will you be able to get down into those weeds a bit?
We're really hoping to. I mean, if we have access to electronic medical records, all of that is documented, whether or not you gave your fluid bolus, whether or not you're using advanced hemodynamic monitoring, what types of medications you were using. Obviously, when we're now developing education and getting out there as much as we can about intraop hypotension and how to treat it. And we're definitely trying to promote, fluids flow, and then pressure, and look at the different medications that we're using. People go directly to phenylephrine infusion, and they've forgotten about ephedrine, so that they may want a little inotropin. So we're just trying to dig in with the education piece. We're trying to dig in with the data and information, feed that back to our providers, so we get a little bit more knowledge and know where to go.
And we all understand the nervousness, but if people don't give it a chance, sometimes things are a bit rocky to begin with, and they don't, they fix the hypotension, they don't fix the problem. Yeah. You've got to give that a chance to mature, and I'm sure you all will. Ashish, have you got involved with this measure at Wake?
Yeah, we're almost there. I will say that we do get our personal quality metrics reported to us. So we report data to something called the Multicenter Perioperative Outcomes Group, or MPOG. We're very familiar with MPOG in the US, gets data from, several large hospital systems in the country. And for example, every month I get sent to myself, and every anesthesiologist in the department, gets data reported back saying X percentage of your patients spent X amount of time less than a MAP of 65, and X percentage of patients had postoperative nausea, vomiting, X percentage of patients were hypothermic in the PACU. So all of us are at least personally very much aware of our own performance. Now, yes, with MPOG, we haven't tied it to a reimbursement yet, but I guess, that is opens a whole separate set of questions. It's if we do tie hypotension to reimbursement, will people just push pressure up without understanding the physiology behind or the pathophysiology behind the hypotensive insult?
Thomas, do you think we might see something similar in Europe now that there's already every standard we look at implies the fact that it's a duty of care to keep the blood pressure up. So there's an argument that we don't need a new standard because it's supposed to be the standard. But do you see it becoming a sort of quality measure to draw a brighter light on it at all?
I don't see it on the national level or on the insurance company level, as you just said. We do have a similar thing on the department level, like audits, where we report back to the individual care provider how he performs. But I don't see it on the national level, although all of us have been forced to install electronic patient data management systems. So these data are available now. Every hospital has it. So these data could be easily assessed, but I don't see it happening because of the data protection issues and all these things, which had to be resolved first.
Well, Thomas, Ashish, thank you so much for taking the time out to join us with great insights, and hope to continue that conversation.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.